Anti-diabetic drugs. First, let's talk a little bit about diabetes. After eating, blood glucose rises. The pancreas makes insulin, which transports the glucose from the bloodstream into the liver and muscle cells and any other tissues where it's needed. This glucose is then stored as glycogen in the muscles and the liver. Blood sugar, blood glucose, cannot cross out of the blood system by itself. It needs the insulin to transport it across. Between meals, blood sugar drops. Glucagon is released, breaking down liver glycogen into glucose. Glucose is then transported back into the bloodstream. It travels through the body and is available to the body tissues for growth and energy needs. When we talk about diabetes, we have to talk about energy. Inadequate insulin means that glucose cannot enter the cells, so the glucose can't be used as an energy source, so the cell's energy is depleted. So the body uses fats and proteins from the tissues for energy. This causes wasting, negative nitrogen balance, and ketosis due to fat metabolism. Uncontrolled, diabetes is a state of starvation. Diabetes untreated leads to dehydration. The increased glucose in the blood pulls water from the cells, causing dehydration. Glucose spills into the urine, causing glycosuria. Osmotic pressure of the glucose in the urine prevents the reabsorption of water. That means we've got polyuria. Putting out lots and lots of urine is going to lead to dehydration, which eventually, as the body gets dehydrated, we're going to end up with oliguria. But because of this process, we also get polydipsia, which is excessive thirst. Now, a combination of the dehydration and the breaking down of fats and proteins in the tissues, we end up with polyphagia, excessive hunger from the tissue loss and weight loss. We have two types of diabetes. Absolute insulin deficiency, that means there's something going on in the pancreas and the beta cells and they're destroyed. So you can't make insulin, no matter what kind of drugs you give them, the body can't make its own insulin. And then we've got type 2, which is an insulin resistance and maybe a secretory defect, just not making enough insulin. There are other specific types, and there's also gestational diabetes, which is pregnancy related. With diabetes, we have hyperglycemia. What do we get along with that? We get glycosuria, polyuria. As we said before, you can end up with oliguria as things get worse, polydipsia, unexplained weight loss, polyphagia, fatigue, and the fatigue can end up going into drowsiness. We have hot flushed skin, dry mouth, and acetone breath. Acetone breath is later in the process as we're breaking down more and more fats, getting into a state of ketosis. You'll see on this slide I have a few things that are underlined: the polyuria, polydipsia, and unexplained weight loss. Those are the classic signs and symptoms that get people to come to the doctor or come to their primary care provider to say, hey, something's wrong. As they move into ketoacidosis, Their blood sugar has been high for a while. They're breaking down more and more fat, getting into a ketotic process that moves to ketoacidosis. We get the deep, rapid breathing, which is the cuff small respirations. The body is trying to blow off some of this acid. We end up with massive dehydration and electrolyte imbalances. We can end up with stupor and death. So what are the criteria for diagnosing diabetes? These are the ones that are listed in your book. The first one is symptoms of diabetes plus casual plasma glucose level higher than or equal to 200 milligrams per deciliter. Casual plasma glucose means it's taken any time of the day. It doesn't matter when they ate or when they didn't eat. The second criteria is fasting plasma glucose higher than or equal to 126 milligrams per deciliter. And the third criteria, remember, all you have to do is have one of these to get the diagnosis, but the third criteria is a 2-hour post-load glucose level higher than or equal to 200 milligrams per deciliter during an oral glucose tolerance test. What does that mean? That means that you come in, they have you drink all this high concentrated glucose solution. They take your blood several times through the process, but at 2 hours, if it's greater than 200 milligrams per deciliter, you get the diagnosis of diabetes. What do we want blood levels to be? Blood glucose level? Well, a fasting blood glucose level, we're aiming for less than 110 milligrams per deciliter. Postprandial, that's after eating, that's what postprandial means. And it's typically about 2 hours postprandial, 180 milligrams per deciliter. We want their blood sugar to be less than that. And we're also looking at the hemoglobin A1C, which is sometimes called glycosylated hemoglobin. Hemoglobin molecules sometimes bind to glucose, and that's what we are measuring. How many of the hemoglobin molecules are actually bound up with the glucose. And this lab is going to tell you about blood glucose control over the last 2 to 3 months. So it's a long-term measure, and we want it to be less than 7%. This lab means that the person can't say, I'm gotta have my blood sugar tested tomorrow, let me be good today. One day is not going to do it, because it tells you over the last 2 to 3 months, how has it been. Okay, so type 1 diabetes, it's the lack of insulin production, or the body's making insulin but it's just not right. Somehow it's defective. That means that the patients need exogenous insulin. What does that mean, exogenous insulin? That means they need to get a shot. They need to get insulin from someplace else. Complications of this is diabetic ketoacidosis, or hyperosmolar non-ketotic syndrome, which is described in your book. Remember, oral antibiotic drugs don't work with these folks, because oral anti-diabetic drugs work to stimulate the pancreas to make insulin, but the pancreas doesn't have the ability to make insulin. So the oral drugs don't work with type 1.